Today, I'm going to talk about hereditary liver diseases. I'm Rebecca VanDyke at the University of Michigan. Hereditary liver diseases account for some patients with chronically elevated liver enzymes, such as AST and ALT, and can lead to cirrhosis and damage to other organs. Although less common than other causes of liver disease, it is important to identify these disorders to provide appropriate family genetic counseling, to identify the appropriate therapy before liver damage worsens, and to provide prognostic information. The three most common inherited liver diseases are hereditary hemochromatosis or iron overload, Wilson's disease or copper overload, and alpha-1 antitrypsin deficiency. All three are inherited as autosomal recessive diseases. This slide depicts the inheritance pattern for autosomal recessive diseases. As you can see, both mother and father contain one copy of a mutated gene shown in the dark or red box, and the normal one is shown in the corresponding gray box. Children inherit either one or two bad copies or no mutated copies, as shown below. The individual who gets two of the mutated copies has homozygous mutation, and they are the ones who can develop disease. Parents and children do not exhibit the disease in these cases. Parents of a patient with one of these diseases is an obligate carrier. Children of patients with this disease may or may not carry one mutation. However, siblings are at risk of developing the same disease. Each sibling of a patient with an autosomal recessive disease has a 25% chance of also having the disease with homozygous mutations. There's a 25% chance of having two normal genes and a 50% chance of being a heterozygous carrier. Once you have made a diagnosis of an autosomal recessive genetic disease, family counseling is important. All siblings of an affected patient should be screened for the disease itself. Parents and children of an affected patient should be educated but informed that they will not develop the disease. The exception is if one parent has the disease, is homozygous, and the other parent is a heterozygous carrier. In that case, each child would have a 50% chance of having the disease. This next set of pictures shows what happens with some of these other family situations. In the first case, you see one parent, the father, who has both mutations and has the disease. He is a homozygous affected individual. The mother, however, does not have any mutations. In this case, all children will inherit one copy of the mutated gene and one normal copy, and they will not have a disease. The next picture shows the genetics of children of an affected parent and a homozygous parent. In this case, the mother is a heterozygous carrier. She has one mutated copy. She does not have a disease. The father has two mutated copies. He's homozygous and he is affected. In this case, half the children may inherit the disease. The other half will only be heterozygous. Let's move on to hereditary hemochromatosis. This is the most common genetic mutation and disease in northern European-derived populations. The disease itself may occur in 1 of 250 people. Heterozygous carriers have no disease. The homozygous affected patients in their lifetime may develop iron overload resulting in disease. This disease is very rare in other populations. There is a gradual increase in iron stores throughout the lifetime, so the clinical findings in the disease usually come on in middle-aged and often in older men who have had many years to get an overload condition. Organ damage occurs when iron stores are excessive. The mechanism of liver disease and hemochromatosis is that high levels of iron are toxic to tissues through oxidative reactions. In addition, iron absorption from food is tightly controlled to prevent overload, as iron is essential, but an overload is toxic. We only have two routes to get rid of excess iron. First, by shedding skin and gut cells, which do contain some iron, and second, bleeding. This is why women are much more protected against getting the iron overload disease, because they are losing blood automatically during the reproductive years. They may develop iron overload after menopause. The genetic defect allows uncontrolled absorption of iron from the gut, thus leading to overload. The next slide shows some of the consequences of hemochromatosis. There are 4 histologic pictures on the left side of the slide. The two panels on the left, upper and lower, show liver biopsies from a patient with cirrhosis. You see nodules of liver cells surrounded by brown or blue material, which is the collagen or the scar tissue. The blue is shown on the bottom left panel. The nodules of liver cells surrounded by the collagen make up the diagnosis of cirrhosis. On the right-hand side, you see the blue staining of iron in liver cells at both low and high power magnification. The cartoon on the right side depicts many of the organ systems that can be affected by hemochromatosis, although liver is the primary one. The heart can also be affected and cause heart failure, endocrine problems can arise, and a variety of others. One should suspect the diagnosis of hemochromatosis and disease due to iron overload if a patient has a ferritin value of greater than 1,000 or an iron saturation value of greater than 45%. Also, if a person has siblings with liver disease, and patients with any chronic liver disease need to be examined to see if they have this disorder. The diagnosis is a gene test. You are looking for a C282Y mutation that is occurring in 2 copies in that individual. In addition, patients may never develop iron overload in their lifetime even if they have these mutations, so you would also want to look for evidence of iron overload before you treat them. This next slide depicts the treatment of iron overload, which is phlebotomy. In this way, you are removing excess iron and preventing tissue damage. Adequate phlebotomy can in fact prevent all of the consequences of disease, but has to be done according to strict protocols, and patients have to be followed for their lifetime. If you have such a patient, you would need to consult with a specialist to develop the right protocol. The next disease is Wilson's disease. This is an uncommon autosomal recessive disease of copper overload that occurs in about 1 in 30,000 people. It leads to permanent liver and neurologic damage. It usually presents in childhood to young adulthood, but can present later in life. The underlying physiology involves copper handling. Copper is essential and is readily absorbed from diet. Copper is removed from the body by the liver through bile in a very well-coordinated fashion so that it does not become excessive. The gene mutated in Wilson's disease has 2 functions. One is in the synthesis of a copper-containing plasma protein called ceruloplasmin. The other is in regulating the excretion of copper in bile. You need to consider Wilson's disease in children and adults with chronic liver disease, with cirrhosis, fulminant liver failure, progressive neurologic disease, and new psychiatric diagnoses, particularly in teenagers and young adults. In addition, some individuals will present as intermittent hemolysis and/or development of bilirubinate gallstones, although this would be a rare presentation. The diagnosis of Wilson's disease is made by a screening test, the ceruloplasmin. This is usually extremely low in patients with Wilson's disease. It is easy to measure, but it can be falsely elevated as it is an acute phase reactant. Therefore, it may be falsely elevated in patients with inflammatory conditions. It is an excellent screening test. However, to confirm the diagnosis, more direct measurements of body copper load need to be made. The 24-hour urine copper excretion is a very well-established test. However, special containers and assays are needed. You may need to contact centers such as the Wilson's Disease Clinic at the University of Michigan to get the materials for the collection and interpretation of results. A diagnosis can also be at least suspected by observing the presence of brown Kaiser-Fleischer rings in the eyes on slit lamp examination. Any ophthalmologist can perform this test. Finally, liver biopsy can be done to measure tissue copper, and this would be a diagnostic test as well. Again, the tissue needs to be specially handled and processed to prevent contamination and artificially high values. The next slide shows the image of an eye with a Kaiser-Fleischer ring indicated by the arrows. This is the gold-brown ring on the outer side of the iris. Genetic diagnosis is not usually possible for Wilson's disease, as over 300 different mutations have been identified in the responsible gene. However, siblings of affected patients might be tested by DNA analysis of SNPs, and referral to a Wilson Disease Center or genetics clinic can be helpful. The treatment of Wilson's disease depends on the severity of clinical presentations. For those with severe clinical problems such as fulminant liver failure, advanced cirrhosis, or significant neurologic symptoms, liver transplant may be the best and often the only option. For asymptomatic or mildly symptomatic patients, copper can be chelated and removed safely over time, usually with oral medications. Patients should be referred, however, to an appropriate specialty center for this, as it needs to be monitored extremely closely to also prevent over-removal of copper. The final hereditary liver disease I'm going to talk about today is alpha-1 antitrypsin deficiency. This protein is a serine protease inhibitor. It's synthesized in the liver and secreted into blood. Its primary action is to protect tissues such as the lungs from damage from neutrophil elastase released during inflammatory reactions. It's present in about 1 in 4,000 persons in the United States. The most common clinical outcome is development of emphysema, as the lung tissue is damaged progressively throughout life. Liver disease can occur in homozygous patients, although it's much less common than lung disease. Liver diseases can present as childhood obstructive jaundice, childhood cirrhosis, or cirrhosis at any age. The defective gene is identified by testing for the actual mutant protein in blood. This is the one genetic disorder where a blood protein is actually diagnostic. Low levels of alpha-1 antitrypsin in blood should trigger specific testing for the form or phenotype of the alpha-1 antitrypsin protein that's found in blood. M indicates the normal protein, Z is the severe mutant protein, and S is a mild mutant protein. The homozygous disease state that results in lung disease and in some patients in cirrhosis is the ZZ homozygous mutation. So who should be tested for alpha-1 antitrypsin deficiency? Any patient with chronic liver disease, any patient with cirrhosis, or patients with severe or premature emphysema. The test to perform is the alpha-1 antitrypsin level and phenotype, because this will give you both pieces of information. Genotype testing is available for the most common mutations and for a null mutation, but does not necessarily pick up every single case. Liver biopsy can be useful to identify the presence of cirrhosis in patients with alpha-1 antitrypsin deficiency and to confirm the presence of liver disease. One can see retained globules of alpha-1 antitrypsin protein in the hepatocytes. It's important to remember that not everyone with emphysema due to alpha-1 antitrypsin deficiency will develop liver disease. This next slide depicts the liver biopsy that's been stained to show these retained globules of alpha-1 antitrypsin mutant protein. The top two pictures show these globules in purple, and in the bottom an immunochemical stain lights up the mutant protein in brown. The treatment for alpha-1 antitrypsin deficiency is shown here. For all patients, we strongly advise them never to smoke, as this will be strongly additive to the effects of alpha-1 antitrypsin deficiency in causing severe and premature emphysema. All patients should get the influenza and pneumococcal vaccines. Patients should get the usual evaluation and treatment for chronic obstructive pulmonary disease. Now, liver transplant cures the liver disease and cures all the disease. However, it would only be available for patients with end-stage cirrhosis due to alpha-1 antitrypsin deficiency, and many patients with emphysema due to this disorder never develop cirrhosis. There is intravenous administration of enzymes that can be done weekly to those with deteriorating liver function, and patients in this category should probably be referred to specialty centers for consideration of this treatment. On this last slide is a short bibliography of some additional reading materials, particularly practice guidelines for handling these specific hereditary disorders of the liver.